Medical Association. And I am so pleased, I'm so pleased to welcome all of you to this afternoon session. It's a discussion about medical education reform. And we're going to have a keynote presentation from Professor Sekelani Banda. There's a few changes to the program as it appears on the agenda, but I am hoping that we'll be able to hear from a rep from the Medical Students Association, as well as from the specialty training program. And we will also be hearing a brief presentation from Dr. Sam Musuri from IHM on innovative health financing for medical education. This conversation is timely, it's much needed, it's something that we've been meaning to have, and I think people have been having in their various private circles for the last several years. I think anyone who is interested in and invested in either medical education or the medical profession recognizes that the landscape is changing and has changed drastically, and that the old systems are no longer fit for purpose. So we are really, really keen to get in front of the problem as best we can. Some may even think or say that we're 5-10 years too late, but the best time to have started 10 years ago, the next best time is today. So that's what we're here doing. And we really hope that it'll be an interactive session. We want solutions-focused discussion. We want to hear everybody's ideas, and we want something to come out of this that'll be very policy-focused, something that we can take to the ministry, to the government, to the people of Zambia, that we can overhaul and fix this system so that it does what we need it to do. Recognizing the various people in the room, thank you so much for your presence here today. And without further ado, I will call upon Professor Sekelani Banda to give the keynote address. Thank you.
I'd prefer it if it would release my hands. I hope I don't switch it off. You want to help? Yeah, so I could have my hands free. Thank you. Good afternoon, ladies and gentlemen, colleagues. I'd like to be grateful to Zambia Medical Association for allowing an opportunity for the fraternity to discuss in detail the matter regarding the state of training of medical doctors in particular, and some of the things will be true for other health professions as well. I wanted to start by basically differentiating what we see and what is actually on the ground. As you can see from this image, you can see a beautiful young lady there, but there's no lady there. There are only branches of a tree, nests, and some birds. That's the reality. And yet, from that reality, we can perceive different things. So, as a fraternity, when we engage in this discussion, I think it would be important to differentiate between our perceptions and what is actually happening on the ground. And also to try and differentiate whether the opinions that we proffer are informed, are researched, are backed by data and evidence, because that's what the current dispensation requires us to do. So as a way of introduction to this talk, I'll first introduce myself and then the objectives of the presentation so that we are clear. I want to introduce some of the things on is it mirror left, on my mirror left, just to give to share some basis. I happen to be a fellow of the Academy of Medical Educators of the United Kingdom. As you realize that in the United Kingdom, to teach in a university, you first must have a doctorate degree, and in addition, you must have a pedagogical training, a training in educational skills. So in the medical setting, you have your specialist training, and then in addition, you must be an educator. I also happen to be a fellow of the Foundation for Advanced International Medical Education and Research out of Philadelphia in the US, a fellow of the Education Commission for Foreign Medical Graduates. Those of you who are attempting USLME or have attempted USLME would have been to the OSCE Center, the Clinical Skills Assessment Center in Philadelphia. And the last one speaks to the World Federation for Medical Education. For a period of 7 years, I was the senior advisor to the president of the World Federation for Medical Education. This background has enabled me to travel to different countries in the world, and only last year, I was the focal point person in accrediting the University of Zimbabwe Medical School with regards to their standards. So some of the things that I'll speak to may get you wondering why they are not homegrown, and that is something that we shall discuss as we proceed. So that is just to set the background that I hope that the views that I present are not uninformed opinions, but opinions that have had the benefit of training and exposure to medical education setups. So I shall give the context of medical education in Zambia so that we are all on the same page. As we begin to critique the state, we must be all on the same page with regards to the context. The basis of critique for me here, I will use the WFME as a lens for the discussion on the basic standards of medical training in Zambia. I'll share some recommendations, and then the panel will give their own points of view from where they are sitting, how they see things, and then we shall open it up. But this session will be very interactive, and I will require some assistance from the Secretariat as we move on, and I shall indicate when we reach to that stage. So, let's begin by understanding medical education in Zambia. I don't know how this pointer works. I have to point there? If I'm standing here? If I point there, it will show there? All right, oops. I can't see it on the screen. Okay, nonetheless, we shall proceed. So, 1964, Zambia is born. Around 1966, the first intake of medical students is admitted, a class of 13, who graduated in 1973. This group of people who have graduated from School of Medicine, some of them, not most of them, some of them in the initial class and the classes that followed start to specialize. So how are they specializing? Most of them go to the United Kingdom, where they become members or fellows of the Royal Colleges of England or Scotland or Ireland. And a few go to do diplomate certification in the US. Now, this is going to become very topical as we go on. So, when you go for membership for MRCP, FRCS, MRCOG, you are going to a hospital where you'll be trained as a registrar in training. People are specifically preparing you to go and sit independently an exam offered by the Royal College. So you are based at a training at a hospital. You will independently present yourself for examination by the Royal Colleges. All right. So a number of them successfully complete these memberships and fellowships and come back to Zambia. A number of them end up joining the faculty at the University of Zambia. Remember? So, the Zambian bulk of people who become lecturers at the University of Zambia have been exposed to MRCP, FRCS, OBS and Gynae, PIDS. As they begin to train, they recognize a need for postgraduate training. And this is common as well to East Africa and other Southern African countries. So, in their discussions, the ministers and the ministries resolve that sending people for MRCA, FRCS in perpetuity will not be sustainable. So a resolution is made that we should try and domesticate postgraduate training in the regions. But how are you going to offer this postgraduate education when you do not have the Royal Colleges equivalent as is present in the United Kingdom? So, the universities are identified as a model for doing postgraduate training. But then these are universities. So the universities will not offer you MRCP, FRCS. So they formulate a master's in medical education, a master's in medicine, MED, in the major branches, medicine, surgery, OBS and Gynae. And perhaps some of you have always wondered why MED was 4 years. Now here is the thing. Master's programs in the university at the most were 2 years programs. So when the MED was born, it was decided that this is going to be a part-time qualification, training, because these doctors are principally providing service. They are working in the clinical areas. So it's going to take, we can't have them graduate within 2 years with a master's. Therefore, this is the reason you find that the MED was initially 4 years. And some of the rationale for that, which is present in Senate papers, is that it was considered part-time. So in 4 years, you made up for what would be a university qualification. There you go. So that set what a number of senior people were exposed to in terms of undergraduate and postgraduate training. Around 2003, the World Federation for Medical Education released what they called basic standards, standards which every institution needed to meet. So the developed world were given more rigorous and stringent standards, but the basic standards applied to the third world. So the School of Medicine at University of Zambia did do a self-evaluation against this. And that is what informed the 2010 curriculum revision. The current curriculum speaks to that. In 2011, we see the emergence of new public schools, the Copper Belt University, and private universities. By 2013, the Committee of Ministers for East and Central Africa are again in caucus, and they are discussing the issue of the severe human resources for health crisis. So they believe that postgraduates can be synergistic in supporting undergraduate training. So they need to have a lot of faculty. However, they recognize that the university model it needs to be supplemented by an alternative if they were to meet the targets. So this is a group of ministers for East and Southern Africa, and they form the College of Health Sciences, EXA. The headquarters is in Tanzania, and I think in Zambia, Professor Vualika sits on the EXA College of Obstetrics and Gynecology. Professor Kraiko used to sit on the College of Surgeons, on the EXA CHS. All right. So Zambia then executes a domestication of the EXA model. And in 2017, the specialty training program is born, mirrored against the EXA community of health. I make this emphasis to make sure that people understand that the STP program is not de novo. It is not an innovation from Zambia. This is EXA, East, Central, and Southern Africa. Fast forward to 2023, we have unemployed doctors. We have licensure exams, which were started, stopped, and they are back on board. And we have student plus. As the way of these key milestones, I wanted you to, so that we are on the same page. As we engage, which we shall be doing, you have this context. If there is any historical inaccuracy in these timelines, please feel free to bring them up so that we can thrash them out. All right. Part 2 of the context. Whilst in earlier days you had just University of Zambia, 13 students, 25 students, 39 students, I think Professor Bo and I, we were 35. In first year there were 250 people, then they selected 50, we graduated 35. And of course, the ministries thought at 35 graduates per year, there was nowhere where we were going with regard meeting the need. But look at where we are now. We have 9 medical universities. 9. 2026, our throughput will be around 3,500 from these universities. 3,500. Foreign trained undergraduates, this could be an underestimate. HPCZ can give the numbers they receive from China and these other institutions. Then there are a few, postgraduate training is now at 150 on account of the one at the bottom there, ZACOMs, and then foreign trained postgraduates, because for the university-based, I did not disaggregate that. So that is context number 2. We have seen the milestones. Now there's a context of how the landscape has changed, totally changed. So somebody who was frozen in 1978 and woken up to today would be completely lost about what is happening regarding training. They'll probably go to their room in D block looking for a neighbor and find that there are bunkers in there with 6 students. All right. Now, pardon my indulgence. I will belabor the point on this slide. Remember the MRCP I talked about at the beginning and the FRCS? Those in medical education parlance are referred to as professional certifications of competencies. The Royal Colleges offer mostly focus clinician training. Their focus is a competent clinician. Academic qualifications, on the other hand, sit in universities. This is where you see Bachelor of Science, MS, Master of Medicine, PhD. Because the philosophy of academic training has a lot of emphasis on theoretical background and research outputs. I like to give this example. If you are FRCS orthopedics, you would probably be doing hip replacements, knee replacements, 30 a year. and your KPI is surgical performance. However, if you are a professor of orthopedics, your KPIs may require that you have had 10 publications, that you are doing research, and that you are involved in teaching. So you can see as just a general difference in those. Now, this is where it becomes interesting. The health labor market basically determines how many doctors we need to train. The need, that is population-based. The disease burden, the number of facilities you have, and how you need to staff them. The training institutions are producing doctors who may decide to work in the health workforce or not. Alternatively, they are being produced, but the many employers do not have capacity to employ them. So you get a mismatch, first between demand and need, and then you get a mismatch between supply and demand. And some of you can relate to what is happening now. 3,500 coming out in 2006. The other arm the country must indicate willingness and ability to absorb them so that they can go and meet the demographic need. And there's no argument about the demographic need in this country. On part B, I'm basically speaking to the health system, where you see that we need to start thinking of health training as fitting into a system. It's in the we are in the pipeline for producing basic doctors and specialist doctors who will go and work in the health system so that we can take care of the population. That was the context. So I wanted us to be on the same page with that regard, so that as we speak to the next steps, we are on the same page. Now, I told you that I'm going to use the World Federation for Medical Education standards for quality improvements. Secretariat, I'll need your indulgence in this. Let me start with the first one. All right. There are 9 standards, so we shall go one by one. The first standard says that a training institution, a medical school, must have a statement of mission and the objectives of the training. And there are categories to this statement. It must be defined by principal stakeholders. This is not a desk statement where you just sit alone and say, I've crafted. The stakeholders, the fraternity, the employers, the end users must all participate in what do we want to see our medical schools achieve. Then there must be a policy on academic autonomy. And I'll get back to this again. Academic autonomy means the training institutions presumably know best because they are academicians. They should be protected from being dictated to by policy, politicians, and other interest groups. Okay? So today someone says, no, introduce a PhD in HIV medicine, or introduce a master's in COVID, pandemic, whatever. A few years down the line, there's no COVID, the HIV, people are on ARVs, it has all changed. So those are just some examples. Or indeed, politicians tell you, increase the number of students from 50 to 200, and you have 15 microscopes. So academic autonomy, at what point does it come in? And then define the competencies that students should exhibit. Now, I'll beg your indulgence. On this standard, if you think Zambia in totality of the 9 medical schools meets all the requirements, you give them 5 stars. If you think they meet most of the requirements, you give them 3 stars. And if they meet some of the requirements, you give them 2 stars. And if we are doing poorly, you give them 1 star. Is it clear what we are trying to do? So this is just a face value assessment. Now, I'll ask you, by show of hands, how many have given Zambia 5 stars? By show of hands. How many have given it 3 stars? 4 people. How many have given it 2 stars? Secretariat, you need to be with me in terms of documenting this. How many of you have given 1 star? Okay, and then a number of you have abstained. But the direction is towards 2 and 1. Okay. Now that you know what we are doing, we are going to go a little quicker. When I'm consultant for WFME and I'm in Zimbabwe and doing this exercise, there are other methods that we must as a committee use to substantiate this. So educational program. Now this says, I'll emphasize some of the issues which are here. You can read them for all of, but you must have basic biomedical sciences in your curriculum. You must have scientific method in your curriculum. And you also should have linkage with medical practice and healthcare systems. Program management, curriculum structure, and those other aspects. This is one of the reasons why, for example, ethics and behavioral sciences were introduced in the curricula because they used to be absent. Now, let's go quicker. 5 stars, show of hands. 3 stars. 2 stars. 1 star. Okay, so here we are straddling between 3 stars and 2. Secretariat, I hope you are taking notes. Then we go to assessment. Here there's a bit of jargon which I'll try and unpack. Are your assessment methods and criteria for passing examinations clear? Relationship between assessment and learning objectives, meaning that your curriculum should have the learning objectives which all the lecturers understand and the students understand what they are trying to achieve. Because if you don't have that, then you just go and present yourself to learn whatever it is that is presented to you. Now, that's not a very efficient program if you are going to be presenting yourself to an independent body for examinations. Now, this is becoming relevant because how many of you are participating in teaching here? Show of hands. A sizable number. How many of you have actually been given the curriculum of the program you are teaching in? So that you know what you are trying to achieve. Now, this is important because at some place, an audit has to take place. You take the examinations and find out which learning objectives the exam questions are speaking to. Not because you've gone for a workshop on DNA sequencing, you come back, you are teaching the whole class is DNA sequencing, which is not stated in the curriculum. Then validity and reliability. Validity simply means, are you testing what you purport to say? If someone has failed anatomy, do they really not know anatomy? When you had only one compulsory question, discuss the anatomy of the distant interphalangeal joint. Is your exam reliable? If you fail in the morning, does it mean you fail in the afternoon? Or do you have situations where you fail in the morning, but in the afternoon you pass? Because you were given a very specific question on a supratentorial space-occupying lesion. Then in the afternoon you are given a pneumonia and you get an A. What is that assessment saying? And some of you may understand that's a prelude to the OSCEs. It's another story on whether we are doing them correctly or not. So, with regards to assessment, how many are giving 5 stars? 3 stars. 3 stars, 6, 10, 2 stars. 1 star. Oh. Okay. So 2 and 1. Student admission. Policy, it's clear how you admit the students, what the basic entry requirements are. The size of intake must be defined and related to capacity. This is what an external accreditator would do. When I come to accredit an institution, or when you are part of the institution, you ask them about student numbers. Then you go and look at their capacity, the infrastructure. And are there infrastructure in terms of library, in terms of laboratory services, in terms of ICT platforms? Is there a correlation? Increasing from 50 to 100, what has happened to your capacity in that? Increasing from 50 to 1,200, what has happened to your capacity? How many are giving 5 stars? 3 stars? 2 stars? 1 star? The house is unanimous. People are looking for 0. Academic staff, your faculty. This is another important criteria. Who is on your faculty? What is your balance between full-time and part-time? What is your balance between medical people and non-medical people in managing your program? How are you balancing their responsibilities for teaching, research, and service? Those are what are considered when it comes to academic staff. Of course, we sometimes have institutions where these things have not been considered, but as an accreditator, these will be considered. So quickly, how many are giving Zambia 5 stars? 3 stars? 2? 1? Okay, there we go. Overwhelmingly, that we are doing very badly on this parameter, which is also an opportunity for people to join academics. Educational resources, I want to belabor this point. We saw it in the other slide, but in terms of capacity, we are looking at sufficiency of the physical facilities. Clinical experience. You all know what has happened now, where there are 9 medical schools, there's only 1 new TH, and now there's levy. And buses come for nurses, for medical students. They park in the car park, the students alight, they go on to the wards, and the buses come back at 16 hours. Who's responsible for those students on the wards? Who is there to see that they are actually getting some hands-on clinical experience? Who is supervising their clinical exposure? I'm supposed to sign 275 logbooks that the students did deliveries. You can understand why I give it to my secretary to sign all the logbooks. Policy on educational expertise in planning your medical education. This is something that we gloss over. For instance, if Senate makes a decision, or management makes a decision which is impacting, or politicians make education, as accreditators, you go and ask them, did you consult your medical education experts on this field? Can we see evidence or proof of their input? Because it might as well you decided to ignore them, as happens many a time. If you second guess that they won't be supportive, you just make a management memo and there it goes. And people wondering, how did this happen but you are also in the institution? Well, you may not be consulted, because until the time of accreditation comes. So with regard to this score, 5, 3, 2, 1. Okay, so educational resources also gets a 1. Program evaluation is straightforward. And we saw it today when we listened to some aspects of informatics. Are we collecting data to use this data to improve what we do? So systematically collecting teacher and student feedback. Some of you may remember in your student days you'd receive a questionnaire. Can you give input on Professor Goma, give input on Professor Boa, and it's compiled. That was supposed to give feedback to the institution so that they can best be informed. And also questions on infrastructure, questions on do you get support, questions. So that's program evaluation. Student performance is supposed to be analyzed. How did the students perform? Is this performance related to the learning objectives, or they didn't do well because we didn't ask them what our curriculum purports that we shall be doing? So you basically get the gist of that. How many are giving 5 stars? 3 stars? 2? 1? Okay. Overwhelmingly 1. Governance and administration. So, governance structures and functions must be defined. Who's responsible for academic decisions? Who's responsible for whether students have failed? This year, people who had two D pluses are writing SAPs. Next year, only those with 1 D plus. The other year, they were all passed because they appealed. Who's making those academic decisions? So, and do you have a dedicated budget? And this is true for most private universities. 60% of the budget is going towards salaries. What percentage is reserved for actually financing educational programs? And then constructive interactions. So, 5 stars, 3 stars, 2 stars, 1 star. Okay, so mostly 2. Finally, it's continuous renewal, which is related to how you are using the data to improve. So we had 50 students. Then we moved to 1,300 direct entry students. Have we analyzed the impact of that? What are we doing about it? Or we heard that Levi Mwanawasa increased their students' intake to 400. They're getting a lot of money. We should also increase to 400. But Levi Mwanawasa has got lecture theater, largest sitting capacity 1,000, 250 sitting capacities, 1,800 capacity lecturer. So it should not be a knee-jerk that because those have increased, we should increase. It should be linked to capacity. So in terms of that, we are continuously improving. Over the years, we are getting better. How many are giving us 5 stars? 3, 2, 1. Overwhelmingly 1. So we might be regressing, actually. So we shall summarize what this, the people here think about if we were to be accredited. Now, I didn't want to give you this information earlier on, but here's the secret. These are basic standards. So to be accredited, you need to score 5 stars on each of those. Now, I'll give you further information. In the past, the World Health Organization used to have a directory of medical schools in the world. But now it has changed. There will be a directory of accredited medical schools. Meaning that all your future interactions will be based on did you come from an accredited medical school. Those of you who went to USLME, to the US, you came to the assistant dean's office requesting a letter, and the school wrote a letter for you. Or if you are going to the UK, the school wrote a letter for you for PLAB, UNZA. Now, those people there will first open their directory of accredited medical schools. If you are not in there, Forget it. There's no discussion. As far as they are concerned, you're not a doctor. Now, this is what we owe our students going forward. Are we going to continue as business as usual, or we indeed owe them to ensure that their qualification has got regional and international recognition? So I'll just go over these, some of the gaps which were found after review. In the traditional curriculum, there's very little to do with health systems, finance, economics, organization, and delivery. And upon graduation, you become district health director, provincial health director, SMS, and the other professionals around us complain that these doctors are being given these responsibilities when they don't even know what a budget looks like. There's very little on evidence-based in terms of emphasis on epidemiology, little on effective relationships, communication skills. Ethics was glaringly there. Now it's a mandate. Every medical school must teach ethics. Otherwise, it will not be recognized or accredited. Medical informatics, leadership, quality measurement, and systems-based. Are you talking basic healthcare package? Are you talking comprehensive healthcare? Are you talking universal health coverage? And what are the implications of that? So these are just some of the gaps. And of course, prevention and wellness. So here are some thoughts around what we could do. All these 9 medical schools, we need to agree that there is a dearth of resources. We may not have the infrastructure that we need. We may not have the academic staff we need. Is there a way we can share resources amongst ourselves rather than operate as silos? We are not ready to share profits. We are not ready to share with anyone. Like I said, there are institutions with an abundance of infrastructure and others with completely nothing, but there's very little collaboration that students from institution A have today gone to institution B because the facility is there. Institution B has said, oh, we have no physiologists here. They have got 2 there. Can you have one come here for 2 weeks to do a module for us? So the consortium of Zambian medical universities is making an attempt to see how we can create synergies related to sharing resources. That will be some more food for thought. Professor Bawa is the honorary secretary. I happen to be the president of this consortium. Then here is, I think, an important point. We need accountability for quality of medical training in Zambia. Now, in the middle, you see that triple helix. It is an attempt to summarize the different career paths that a medical doctor and a pluripotent medical doctor, when they just graduate, what they might end up to be. They might end up as a clinician. Certify them for their clinical competence. They might end up as an administrator. Certify them for their competence in admin. Or they end up as an academic. Certify them for their competence in academic. So, from academic point of view, we must certify the educators and accredit the institution. So as a collective, as a fraternity, we must say we want to see that our institutions are accredited. We want to see that the educators know what they are talking about. They have the basic understanding of facilitating learning, theory of practice of assessment, curriculum development, educational leadership. I've seen people administer an OSCE and the distribution of marks. Standing on the right side of the patient, 5 marks. Greeting the patient, 5 marks. Warming your hands before palpation, 5 marks. List of investigation, 5 marks. Diagnosis, 5 marks. The student already has 15 out of your 20 or 25. Just by standing on the right. Because you don't understand that there's things like weighting of the scoring sheet. There is a blueprint. How many systems did we teach? How many competencies did we teach? Are they all represented in this exam? No, just that space-occupying supratentorial region. Curriculum development. We have said about these gaps. If you are given the task to develop a curriculum, do you have the capacity? And then, of course, the educational leadership, where you understand the statutes of the country, you understand the role of HEA, HPCZ, and things like that to participate. That will bring accountability for medical training. I thank you.
Thank you so much, Prof, for that rousing presentation. And I think it's very obvious that we have a lot to do before we get where we want to be. So we're going to have a few short presentations. The people who are going to form the roundtable discussants. We'll start with Dr. Sam Musariri from IHM, and I'm sure you'll give a much better self-introduction. And then we'll have another brief presentation from Dr. Shailin Desai, just giving a bit of the private practice perspective on medical training, what we need to know if we're going to engage better. We're also going to have a representative from the STP program, and then we will close out with Professor Goma. We may have somebody from the undergraduate students, but it's he's seems to be AWOL at the moment, so I will provide an update on that. Thank you so much, Dr. Musariri. Please go ahead.
How do I change the slides?
There is a clicker. Let me just ask Prof.
Okay. No, I think there's a his. Okay, good afternoon, everyone. My name is Dr. Sam Musariri, and I think our ride on the protocol is already established. I want to take cognizance of our senior doctors, colleagues in the house. So I'll be presenting on a very short presentation regarding opportunities for financing for post-graduation doctors. I think Prof has done a splendid job in laying the foundation of where we are coming from and where we are. And as someone who's been taught, I think, by most of our senior colleagues here, and also experienced a bit of the industry, both in the private sector, in the government, self-employed status, and also in the NGO space. Most of these thoughts, I think, have been formed over time in discussing with colleagues and brainstorming these questions and trying to take cognizance of where we are, acknowledging the realities of where we are, but also thinking about what are the possible solutions considering our current status. Okay, are you able to change the slide for me? Okay, so I think it's befitting that we start with a SWOT analysis, or at least an evaluation of our current status. I think Professor did a wonderful job of giving us the history, the trajectory, and where we are. Regarding doctor employment status, I think as of the last employment round, of which 11,000 healthcare workers were employed, we had about 800 doctors applying, and only 511 were taken up. Okay, at present, we have about slightly over 1,000 who are registered with HPCZ, and by the end of the year, we'll be having close to 1,700. And this number will grow to about 3,000. And if you consider, I think with also the background the professor gave regarding the number of medical universities we have, if on average all of these are producing 100 graduates, that's easily an additional 1,000. And I think he put it aptly when he said we'd be looking at 3,500 per annum. So where do all these people go, and what are we doing? What are the thoughts around what are the opportunities in the market, and how do we create these opportunities for our upcoming doctors? Next slide. So I think one of the things that is often missing when we are discussing employment for doctors, it almost seems as if there is an unlimited budget or unlimited purse. And the government has this unlimited capacity to employ, which we all know it doesn't, okay? So the government published their financial results for 2022. And as you can see, the budget for 2022 was standing at about 133 billion kwacha, which is obviously all intended to be spent. And roughly about 53% of this money is going to pay workers as well as reservice debt. I think in the past, this amount has been as high as 90%. And for me, the message this brought was the fact that there is definitely a ceiling, a hard ceiling, to how many people government is actually able to employ. And definitely that will not be 3,500 every year. Next slide. So given this situation where we are, and I'm glad I think we have a lot of decision makers, stakeholders in the room, and I think these solutions are meant to probe us, to ask questions and to see what options we can actually bring to the table. Next slide. So we know that one of the policies that the government has taken currently is to begin to emphasize devolution with a message of decentralization, moving away control, moving away funding to councils, to district level. And one of the conversations that has been had is around what opportunities does this then create to create employment opportunities for our colleagues who are coming, some of whom are already waiting to be employed. We know, for example, that there's been a substantial increase in CDF, I think currently standing over close to 28 million kwacha. What does this mean for us, and how do we take advantage of these resources that are being pushed into these constituencies to be able to create this employment opportunities for our colleagues who are coming after us? Next slide. Revision of internship, I think, has been a hot topic. I remember when I graduated, we had the HRR colleagues who came, gave us all forms. In fact, they were just asking us, where do you want to go? I want to go to Lusaka. Where do you want to go in Ndola? And it was easy and straightforward. No one had issues around how long should internship take, because all of that was funded. When I interact with a lot of our younger colleagues now, a lot of them are either doing internship at their own cost or finding mechanisms and ways in which they can foot the cost of doing internship. So this obviously brings about the question, is there a need to relook at the duration of internship? What are those specific skills, knowledge, attitudes that we want to impart into these people? And is it possible if we can reduce this time period to a year, for example? So I think with the expertise that we have in this room, I think it would be important to discuss this and look at what are the possible alternatives. The second component which has been discussed around this is, are we able to extend internship opportunities beyond the government facilities? As it is, only government facilities are able to train an intern doctor to be able to be certified. But what is the possibility to extend this to different institutions, given the sheer numbers of medical doctors that we have? So again, these are thoughts that we need to deliberate on and really come to consensus as a group. Next slide. So Professor Sekelani Banda put up a very interesting slide where he talked about a value chain. And that value chain begins with a need, the target that we have as a country to be able to provide the skilled human resource to serve the people. So we always have these numbers that are usually produced around what is the ideal doctor-patient ratio, and that obviously educates the need. But at the other end of the cycle is obviously the demand. How many people can the system actually absorb? So it's very easy once you are in an employed position to obviously have these conversations with less emotion. But when you consider the fact that some of our colleagues, I was speaking to some junior doctors who were telling me some of their colleagues are now working in ShopRite, others are working at mobile money agents, just so that they can raise some money. But at the same time, we know that there's a huge demand in the diaspora. For example, Germany, Canada have all put out calls for medical experts to attract medical people into their countries. And if you look at the numbers, the African diaspora sends back over $100 billion in remittances back into Africa, which is way higher than what we actually get as a continent when it comes to foreign aid. So there is obviously this huge demand for healthcare workers in the diaspora. What are we thinking around training our people for export? Because obviously, we might not be able to absorb most of this capacity in the near future. Next slide. So some of the, for me, I think some of the innovative things that have come out recently, I think we saw a publication by Cavendish Medical University with the fact that they had partnered with a Finnish medical institution. Finland has demonstrated that they've got a 30,000 nurse deficit. And on average, if you work out the mathematics of if we send, or if we meet just 20% of this demand, that could mean $53 million in remittances back into the country. This obviously helps our economy, provides jobs for these young people, and obviously with a growth in the economy, the capacity that we have to employ more people is enhanced. So I do think that there is a conversation to be had around what are our thoughts around training these people, training our young people for the diaspora, and equipping them to be able to work in jurisdictions beyond Zambia. Next slide. Another, I think, interesting mechanism to finance education, which I think is very popular in the global north, is what they call income share agreements. So an income share agreement is essentially a mechanism where you identify high income earning individuals. So often this tends to be software developers, but obviously healthcare workers would fall in that bracket. And when you speak to a lot of these people that are looking to go out of the country, one of the biggest hurdles they have is just the cost to transit, okay? So there is, for me, I think there's a conversation to be had around, is there a fund that we can create that can support these young people as they transition? They're funded to be able to foot those costs, and as they get these jobs, part of that money is remitted to repay that finance. And this can become a revolving fund that supports more and more young people to go out and to be able to deploy their skills. We have one such example, which is based in Nigeria, which is focusing mostly on software developers. And as I've mentioned, the majority of this talent is being trained to serve the global north with the demand that they have for software. But obviously the demand is there as well for healthcare services. Next slide. I think another thing of note that we cannot run away from is the sheer volume of funding that the public health sector gets. As of 2020, the aggregate value of funding that came into health-related funding from many different donors, multilateral organizations, was over $1 billion. Okay, and this is many times multiples of what we're able to generate as a country to be able to engage and employ our people. Is it possible that we can begin to consider tweaking some of our education so that as these young people graduate, they are more tailored to work in NGOs, in public health, and they can use that initial funding to be able to finance their internship? Some of these conversations are being had. A lot of young people that are working in some of these places are raising money so that then they can fund their own internship, and then after that be able to look at taking care of themselves once they've graduated and have got a full license. So again, I think this is a conversation that we need to have, considering the facts on the ground and looking at what become the possible alternative solutions to provide our colleagues with that ability to be gainfully employed. Next slide. I think another opportunity that has presented itself in more ways than one, and I'm glad that Dr. Luando from NEMA is here, is the opportunity that is present with NEMA. NEMA has obviously over the years built a healthcare fund, and they've also demonstrated the need for them to provide cost-effective services in underserved areas. I think as of their last call, the emphasis was really around how can we get some of these services going away from the line of rail, because the majority of NEMA accredited facilities typically are along the line of rail. So is there an opportunity then to begin to use telemedicine, to begin to put up certain telemedicine centers that these young people can begin to work in, provide a service, and obviously NEMA as a compensation mechanism can provide that vital employment opportunity for them. Next slide. Last but not least is public-private partnerships. So I think one of the things that has come out recently from the government, and this is as of, I think, 28th July, 2023, is a revision in our PPP Act. The government has made a move to encourage more partnerships in working with the government. I think a lot of conversations have been had around, is it possible then to create group practices that are headed by senior doctors where junior doctors can be employed, and government funds the initial capex to set up the infrastructure, and these are then given to these group practices for them obviously to be able to run, and that process of running and managing those facilities then obviously employs various healthcare workers. The other day I was having a look, or rather we're having a discussion around the CEC Act. And if you look at a number of our laws and a number of our acts, you will find couched in there employment opportunities, but mostly for lawyers and accountants. So if you look at, for example, the revision of the Solvency Act, which has been revised to include business rescue, they've made it very clear that the only practitioners who can do this are lawyers and accountants. And obviously this creates opportunities and employment for that particular segment. Is there a way in which we can begin to take an active step when it comes to some of this legislature to ensure that correlated service areas also create opportunities for health workers to be employed? Next slide. And finally, my last slide, I think for me is something which is very, very critical, and I'm a beneficiary of that process myself, which is mentorship. And this is probably the lowest hanging fruit, in that a lot of us who've spent time in the industry, at least 10 years or older in the industry, really need to play a more active role in engaging some of our younger colleagues. A lot of our young people, I think, if we were able to translate some of the things that we've learned over time, the good lessons, the bad lessons, I think would enable them to begin to find some opportunities in some of the areas that we've either worked or where we have colleagues who work in those spaces. So I think it's also incumbent upon us colleagues to begin to look at the next generation and also ask ourselves, what role are we playing to capacitate these young people, to give them those skills, those values that they need to equip themselves with to be able to ensure that they are able to get some form of gainful employment in their career. With this slide, I come to the end of my presentation. I thank you very much.
Thank you so much, Dr. Musariri. I really, really love that topic. The money is there. The money is there, and what we need is the leverage and the ideas for how to get at the money, how to spend it to our advantage. Personally, I never want to hear the conversation about, no, they should be volunteering ever again. There's definitely ways and means, and I think it falls to us to make sure that we capitalize on them for the future of the profession. It gives me great pleasure to call upon Dr. Shailin Desai, who is the director of Kabalenga Family Hospital and has a lot of reach in the private sector in terms of private practice, to give some thoughts on what we would need to do to properly engage the private practice.
Thank you. Good afternoon, colleagues. I think I've been introduced already. I was caught at gunpoint to say a few words on the private practice and medical education, and I have no issue giving a perspective on the private sector with regards to medical education. I think some of us might know the history of the private sector in Zambia. If you go back just maybe 15 years ago, Lusaka was probably the only one that had any facility that one would call a hospital. But majority of the private sector players in Zambia were little outpatient clinics. And as such, when some of us graduated, private sector was not even thought about as a major player in the health industry. But over the last 15, 20 years, there has been a revolution in the health industry. And we have private sector players not only in the education field, like the private universities that we have everywhere. The healthcare providers have increased. Yes, the pharmaceutical sector has done much better than us doctors, but we are growing. Can the private sector help to bridge this gap that Prof. Banda clearly elucidated for all of us? We have all these buses going into, I see them when I drive up and down, buses with nursing students, medical students, pharmacy students going into either UTH or Levy in Lusaka, and we all hear that on one ward round there would be at least 20, 30 medical students and nurses. When I trained, I remember professors would start asking questions from a student nurse up to matron, fifth year students, seventh year, registrar, senior registrar would finally mop up. That's how easy it was. So you'd have like 6, 7 people on a round with 2, 3 students. And we learned with hands-on. We were always told your teachers are not the textbook, but your patients. So get yourself to the ward. Don't expect to be taught in the classroom. Don't expect to be taught in the lecture theater. And we had rough lecturers. They never smiled, you know. Now I wonder what sort of graduates we are producing. It's sad sometimes to sit in an admin position like I am in and interview a doctor who has passed and has graduated and is registered. That was before the licensure exams. If you trained in Zambia, you would be registered. You would do your internship, or probably not even. And you're just having a chat and see the kind of information that is lacking in this graduate. And before, there were a few universities you would ask, so where did you study? And if they mentioned a private university, you were like, oh my Lord. You know, they had very few lecturers at the time. Now the faculty seems to slowly be growing with many specialists coming up. The private sector definitely, I feel, in my opinion, can help absorb some students, be it postgraduate students or the undergraduate students, to provide clinical training. But there's a catch there. If you look at Lusaka as an example, I think we have 2, probably if you add Mainasoko, 3 big hospitals that have all departments functioning at 70, 80% capacity. The rest are smaller hospitals, according to the HPCZ register. That's, if I'm not mistaken, class A1. Those are the majority hospitals in Lusaka. On the Copper Belt, even smaller. The rest of Zambia, there isn't much happening there. But we can still absorb some of these students. How could that happen? What's the challenge? Why doesn't the private sector take up the challenge? There have been conversations for the last couple of years. A lot of us have sat down with policymakers, decision makers, up to the ministry level sometimes, to give a perspective on how private sector can help. It might not take thousands, but it could make a difference. So one of the things I see that can help is if we agree as a country to start thinking beyond UTH and Levy and Ndola's Teaching Hospital and rope in these private sector institutions. Take an example that I will probably use my own facility, Kabelenga Hospital. It has 2 surgical theaters, fully equipped, fully registered, accredited, and the obs and gynae team is doing wonderful work there. And then you take maybe CFB, and they have a CT scan and an MRI. Sorry, I'm mentioning names of hospitals, but I'm using them as examples. And HPCZ, that's why I say if all of us agree, HPCZ comes up with policy. Like Prof has mentioned, the consortium of universities. We register an internship site, but it's 3-4 different facilities. You spend 6 months in this institution doing obs and gynae. It's accredited because it has everything for obs and gynae. You spend your 3 months in this other facility, however the internship planning is done, if it's 1 year or 2 year, it can happen. Prof. Goma was in private practice and he knows what I'm talking about. Certain institutions have capacity in certain areas and may not in other areas. But it definitely can help change the narrative. And as we grow to different parts of the country, I assume that we'll be in a better place in the next 5 to 10 years. Whether it's directly universities going to the private sector institutions and rounding us up and saying, okay, 1, 2, 3, 4, we've identified you. But there has to be policy around it. The reason we're having this conversation, and hard conversation, is because we can see there are big issues. The scorecards that Prof was putting up, most of us were sitting at 2 and 1. That's a damning situation for all of us. So I do strongly believe that the private sector has a role to play. It can happen, but it starts with policy. We are too rigid with ourselves. The medical sector is very rigid. Look at the accountants. You can pass and immediately go and do an internship at a private sector. You don't have to be, you go to Deloitte, even lawyers. You will do your internships, you will go to court, but you are being supervised by a senior lawyer. You go to Ziale, which is your licensure exams, and you pass. And that's it, you're practicing. But the medical fraternity is so fragmented, and we are very, I can't even find the right word. We just really don't want to work together. You know, what Prof has presented to us is thought-provoking. I know he has made a lot of us think, those who think STPs are not good or MEd is the only way to go. I think if you listened very carefully, it was very thought-provoking. And we should start thinking like that. So for me, yes, the opportunities are there. There are challenges. Challenges obviously are more with regulators and policies, which can be sorted out. We have enough professionals that can help teach currently in these few facilities. We don't have so many private sector facilities, but we are growing. We are growing. I think I was asked to say if there's anything that can sweeten the pot. It's not even about making the pot sweet. Many of us in the private sector are now hoping to see our country much better. We get very upset when you see a client and then they tell you, oh, I'm flying out because I don't think this can be done in Zambia. I was sitting at the Royal Livingston 2 days ago. We've been here. I sit on council. And I was having dinner with some friends there. Zambian family, brought up in England. They were sitting there and I was introduced as a doctor. And the gentleman says, oh, I'm flying back to England because I have an appointment to do a hernia surgery. I have double hernias. This is a Zambian, but brought up in England. But I've just received an email that it's been postponed. This is the third time it's being postponed. So the gentleman who had invited me says, but you know, here is Doc, ask him. I said, oh, I don't even know what to say. Because hernias are done like, I think even when I was training, we were being taught at undergraduate level how to do hernias. And when you went for internship to Ndola, there was only one surgeon, so you had to do those things. Although it was not right, but we were doing them. But now, postgraduate students do this, and the first years might be doing thousands of hernias before they even get to second year. So I told them, I said, you know, honestly, you can have your hernia today. From here, I can call you. I can call somebody, even in Livingston. And 48 hours later, you'll be discharged. If you're flying, fly to Lusaka, rest for a few days, and you'll be good to go to England. No postponing, nothing. Absolutely nothing. It will be done. So it really hurts when you hear people saying they want to fly out. I don't know how the rest of you feel, but for me, it's burning. It's a burning issue. And I keep on pushing the agenda that as Zambians, we need to take over the private sector industry. Stop saying that, here, niva mwenye chabi. Niva ku Bangladesh. What are we doing? It takes back-breaking work to own that clinic and to make it run. Don't think that because you are Dr. Who and you're going to open a clinic, you're going to make that money within a year or two. No. It's hard work. But it can be done. Make that name first. Not the name that you have at UTH or wherever. No. Remember, there's a different cohort of patients that we are seeing. But it can be done. And I urge a lot of you to think about the private sector. There is a need of healthcare. Our people need healthcare. I think I want to be a devil's advocate here. We have been crying about internship sites and internship placings. I have, in the last few years, argued with people at policy level that this internship, why should it be tied with the positions for employment? Why should internship be tied with the number of slots that are there for employment? I can't understand it. Yes, people might say, hey, but Doc, when you graduated, you were employed. Yes, there were 40 of us in my class when we graduated. And like Sam said, we were not allowed to choose, but I just saw a list. I mean, we finished an exam on Friday, and we were told, please don't go. Tuesday, the results came out. Oh, you guys have passed. Wednesday, we were getting fingerprints. Friday, we were sworn in induction. Saturday, there was a truck at Ridgeway from the Ministry of Health and a bus. 23 of you, $11, and the rest of you, Kitwe. Off you go. We were employed. But it's not the case now. Let's face reality as it is. I think we need to start talking amongst ourselves that internship and employment should not be the same thing. It's not like that in the other sectors. Why do we want to continue fighting this? So I think I'll end there, and hopefully I've provoked some thought, and also we need to start discussing how, like I said, policy can be changed to involve the private sector. I'm sorry I didn't prepare slides or what. I was caught at gunpoint. But thank you so much for your attention.
I think we can agree that that was an excellent presentation. I am the one who was holding the gun, but I think Dr. Desai more than delivered and gave us a lot to think about. I think we'll just go straight into calling calling upon Dr. Mubanga. Are you in? Excellent. Who will give a bit of perspective from the point of view of the specialty training program, which Prof. Sekalani Banda mentioned as one of the innovations of medical education that happened in recent years. Please go ahead, Doc.
Thank you, moderator. Good afternoon. May I ride on the protocols already observed? My name is Dr. George Mlenga Mwanga, STP3, Obstetrics and Gynecology at Choma General Hospital. I'll take you through a very short presentation just to highlight a few challenges the STP program is facing from a trainee's perspective. Next slide. So this is the outline of my presentation. Next slide. Ladies and gentlemen, at this point, the STP program requires no introduction, but protocol demands it, so here goes. The Zambia College of Medicine and Surgery, ZACOMS, was registered with Registrar of Societies on the 17th of November, 2017. It was created as a collaboration between the Ministry of Health, the Zambia Medical Association, and the Health Professions Council of Zambia. Next slide. I'm not audible. Okay, thank you. So the college was formed in response to a critical shortage of specialists in the country. It has since successfully graduated 3 intakes with a total output of 202 specialists, the biggest number this country has seen this far. However, the program has had its fair share of challenges, and I'll highlight a few here. First one being inadequate funding and how this has impacted the training. So inadequate funding has had significant and far-reaching impacts on the specialty training program, and some of these being the quality of training. As you may be aware, that our trainers are not incentivized, they're not motivated financially. So this simply means that we cannot hold them accountable for the kind of training they give. It is basically at their mercy. The other challenge is that as of this year, trainees sitting for exams will be required to pay $6,500 each. This will go to the preparation and setting of exams. Now, I believe that if ZACOMS was adequately funded, trainees would not be required to foot these bills. The other challenge is that we have limited exam centers. This means that trainees have to travel to either Lusaka or the Copper Belt to sit for an online exam. Now, with adequate funding, we would at least set up a center in each of the provinces, which would reduce the burden on trainees who are having to travel to go and sit for online exams in Lusaka or on the Copper Belt. The other challenge is the issue of study authorities, study leaves. These challenges are at facility, district, provincial office, and at ministerial level. So the beauty with the STP model is that trainees are not removed from their centers, but rather they will apply to be in school at their centers. So it doesn't really take away the manpower, but the manpower is actually retained at the center. So then, how are we having challenges with giving authorities for trainees to be in school
when they're actually going to still work in the very centers. If the powers that be, maybe present today, would really use your assistance in these issues. Then we have pending MOUs with universities. Just a bit of background. So the STP qualification is more of a professional qualification. The MOUs with CBU and UNZA were to enable trainees who want to do research at the end of a year obtain an MEd. So if these are to be actualized, this would be actually a great milestone for the college. One that has been done is with Levi Mwanawasa University, though it is not yet operational due to a few rigidities in procedures. Stipends. So each trainee is entitled to a 5,000 kwacha for every year of their program. Now this is stated in the binding contracts that MOH signs with each of the trainees. Unfortunately, only a few people have received these stipends. Follow-ups have been made, but to no avail. Then we have the issue of rotations. So at one point or another, trainees are required to rotate in these hospitals, the big hospitals with sub-specialties, mostly Levi and UTH. So we find ourselves in situations where trainees are not released by their facilities to go and acquire these skills that definitely are much needed for someone to become a specialist. Then the other challenge we faced with these rotations is that at these centers where we are supposed to go and rotate, mostly UTH again and Levi, there's limited accommodation. We have a very limited number of flats allocated to us and a very big number of trainees required to rotate through these centers. This has forced trainees to have to rent houses in Lusaka, bearing in mind that wherever they're coming from, they've left their families, they are maybe renting or doing other things that side. It has become a financial challenge, a burden on most of the trainees who have to do these rotations. We can never undermine the score of the importance of these rotations for a specialist who is coming maybe from, say for example, I'm coming from Choma. I have to go through Lusaka, UTH, maybe Levi and other centers just to get the feel of how other teachers are teaching for someone to become a full specialist. I think this is quite important. So the issue of accommodation is one of the biggest challenges that we have faced this far. I think on that point, I end my presentation. Thank you.
Thank you so much, Dr. Mubanga. Hard to hear, but the stark reality of what it means to be training in 2023 and beyond. So just to make sure, I think we were expecting Professor Kayamba, Violet, but I believe that she's not in. We've been trying to get a hold of her. But in case you are in the room, Prof. Going. Okay. In which case, I am very pleased to say that Professor Goma is going to give us the anchor presentation and will give us thoughts from the perspective of HPCZ and a lifelong educator as well. And then after that, I will hand over chairing duties to the MERB Secretary, Dr. Clay Suwale, and I will invite all the presenters to come to the front and give their further thoughts and answer questions from the audience. Prof. Goma, it's a pleasure to welcome you to the podium.
Thank you very much, Chileshe. And it's good to meet and discuss these issues. And I think one thing that I do miss being in my office is standing on my 2 feet and speaking my mind. I've been taught to be a diplomat, I've been taught to shut up and to listen. And I think that is what I'm learning to do. And my role really at HPCZ is to try and do what the profession says is to be done. You will see that our keyword is compliance. We want people to be compliant with what they have put out to be done by themselves. I think that is why this is a self-regulating profession. And so what we would really want to do is to see to it that the profession is delivering on its promises, so to say. And so, when it comes to training, I had a problem trying to prepare any slides for this particular topic, because I know, we all know what we are talking about. But what we should be doing now is making decisions on the way forward. What shall we do to make sure that the people who are coming out of these training colleges are fit for purpose? People who are going to look after us. I know soon we'll be needing our hernias to be sorted out. We have obviously the prostates to be looked after. Are the people we are producing fit to look after us? Or shall we get insurance and fly out? For me, I think that is a question we should be asking. Zambia has been well known for having quality doctors and quality specialists, meaning that at every level I think we have done very well. And we have had other cadres being produced, clinical officers being the closest to us. But really what has happened in the last few years is what is surprising. I really don't think we have ever thought of producing clinical officers en masse. Suddenly we have thought of producing doctors en masse. And I'm wondering, what is the profession doing about this? You will note that in every production line, we think of the products that are going to come out, and that they will go out there and be serviceable. But medicine is different, and I hope we can go back to the ethics of medical training. That this is a profession which is built on compassion. To a large extent, it must be seen to be a calling. And as such, you don't just get people and train them like the way we train policemen. No. There must be a process, isn't it? Our colleagues have always a way of doing things. I was talking to our friends from Ghana, and they are saying up to now, they have to have their candidates, after their O-levels. They write aptitude tests, first of all, to try and see whether by aptitude they are meant for the social sector. Beyond the aptitudes, they bring them to interviews. And beyond the interviews, then they admit them into the 7 medical schools that they have. That's where it starts from. What are we doing in Zambia? Admission on the spot. Just give you my grade 12 results. Here, I want to do medicine. Oh, do you have a 6 here, a 5 here, a 4 here? Come. Such and such a university gives you a letter of admission today. And I was surprised that even UNZA joined that bandwagon. Admission on the spot. Okay? This is the way we admit people to medical school? Probably to a university, yes. Because the universities are under the Higher Education Act. And the Higher Education Act, I think, has given universities way of admitting their students. Okay? But for us in medicine, I think we have made it that, people come to medicine with qualifications which have put them at the level of A levels. Compliance, ladies and gentlemen, comes in. Meaning that admitting students to a medical school at first year, just with their O levels, is not compliance to set out, I shouldn't say regulations, because these are, I think, are agreements that have been made by the profession. We have said that they are supposed to be admitted after they have done their A levels. And then they are admitted into an institution. And that institution must be approved to offer those programs. How have we featured over the last few months? We haven't featured very well, of course, because in 2018, the Higher Education Authority Act was changed, which took the responsibility of accrediting institutions to HEA, and they said HPCZ shall not accredit training institutions, which was an anomaly, because the Act clearly says that HPCZ shall approve the curriculum that is to be delivered in those institutions. If you approve the curriculum, then you should be ready to regulate the delivery of that curriculum. And I think that is what was lacking in the amendment that was done at that point. I think we are up to it now that we have agreed with HEA that we will do what was intended, that the two of us are in this same space. What we want is to get a qualification for a candidate that will be recognized internationally. Prof. Banda has already said how important it is that when you give them a degree certificate, they should be able to say, oh, you come from such and such a university? Yes, we know who you are. Otherwise, we are going to have universities which will only be recognized in Zambia. Probably only in Matero they will know that there is this university. We will be moving forward to make sure that the delivery of that curriculum is as has been agreed. Now, that obviously goes with advice about, intakes, about student numbers and things like that. The problem we have, ladies and gentlemen, is the numbers that we have right now. And we need the profession to advise what is supposed to happen right now. I'm sure you know, we have colleges which are overloaded. And in my view, we cannot say they are studying medicine. They are studying something like it. Okay? We have a class with 2,300 students. That's a fact. I'm told it's divided into groups. I don't know exactly how those groups go to class, how they learn. I don't know exactly how many cadavers they have acquired for that particular class and how it's going to operate. But that class is going on. Okay? And at the end of this year, I'm sure they say, oh, they have finished their year, they can proceed to the next year. Should really the profession accept that those people are becoming like them? Those, I think, are issues that you as a profession is supposed to be talking about. We need to insist on the institutions to have an environment of an institution. You don't want people to be training anyhow, anywhere. Ladies and gentlemen, we have said we will train in a medical school. And you know what a medical school should look like. It should look like a medical school, isn't it? So just have it in your mind. What should a medical school look like? I don't think it includes a bus. Or it's only a bus. Huh? I don't know. Goma College of Medicine. The guy only has a house and a minibus. In the morning, it takes the students, takes them to Levy. In the evening, it brings them back. And at the end of the day, we say they have learned medicine or they have become doctors. I think a medical school has more to it than just going to a hospital or just going to a lab or just going to a classroom. That is why we talk of classroom size and we talk of faculty. There must be a way in which there is this interaction between the learner and the teacher. A healthy, happy interaction. There are these interactions among the learners themselves. Healthy, happy interactions. You are moving together, you are learning together. One day you will graduate and become doctors. We want to see that. We want them to train in institutions where reality is really the ultimate, so to say. It's clear that training must be done in a tertiary institution. Tertiary. There's a reason why that is there. Now, shall we create a tertiary institution in a first-level hospital? Those are questions we must be answering for ourselves. No, just because, Professor so-and-so has retired, now he's at Kanyama Hospital, so he can teach our students from there. Are we going to accept that as a way of training medical students? We really have to try and look at these issues very, very seriously. So the institution that they're training must be an ultimate institution. Why? Because when they graduate, we know that whatever institution they are going to go to must be an institution which is lower. Okay? They must say, well, where I come from, this is what we do, but here I don't have this, we are going to innovate. And it's this issue of innovation that should make us also think about aptitudes in the students that we are taking. Okay? There must be people who have a particular acumen, people who can think fast. I don't want to use a word that I like using. But people who can think fast and can innovate, okay? So they will know that, well, I needed to use a mesh to do this hernia. But this is JAMA. There's no mesh here. What do I do to sort out this hernia? They should be able to sort it out. But if they train in JAMA, and then they come to UTH, and someone, oh, I want to do a hernia. They find there's a mesh on the operating tray. That's just wondering now, what is this? No, Bwana, this is for the hernia. Oh! Huh? Now, strictly speaking, that is not what is expected. Okay? I really think that in all the training functions, we want to have a step down type of process. Okay? So this is where we are coming from. So as HPCZ really would want to make sure that the training institutions are compliant with the training processes that the profession has put out for itself. So ladies and gentlemen, we are here to listen. We would want to hear from you what you think should be done to make sure that the current is corrected and we prepare ground for the future. Okay? Second thing about the health facilities. The health facilities clearly defined. This is the way we handle issues here. Then we look at what was done. Say, okay, was this to standard? Was it not to standard? Okay? And so the work that Health Professions Council has is supposed to be very straightforward work, in that we follow the written word and we compare with what has already been put out. So there's no room for opinions, okay? There's no room for arguments. And I think this is what makes us to be distant from lawyers. You know, lawyers like arguing. And if you can't agree with them, let's take it to court. The courts are going to determine. But here, we work on science, we work on evidence. And from there, we come up with the evidence-based decision, saying this is the way we are going to do this thing. And so we are hoping that those things will be done. Well, talking about that, as I said actually in the morning, I thought we are going to have a session just for HPCZ to share with you what we are hoping to do going forward. So I'm hoping that President is still looking at his programming, so that we have that session, so that we can talk a bit more things outside training. But for now, let me try and stick to training. But otherwise, I'm almost there. Okay. So, in terms of practice, I'm now talking about health facilities where these people train. I started by talking about training institutions, but now the health facilities where these people train. Ladies and gentlemen, we have to make sure that the health facilities where these students train have what it takes to produce a good practitioner. Diagnostics and therapeutics. We need to insist that these are always there. They have to be. Why? Because students are there on a 24-hour basis, so to say. So if we do have a stock out, there's a problem, because one group may actually be there when that thing is not there. They will miss out on the learning. I think once a health facility has committed itself to training, it must go an extra mile in making sure that it provides what it takes to provide good teaching service, so to say. And I think that is why, for every program, we insist, that government comes in, it brings in the needed resources. If not, then we look for partners. Let those partners bring in the necessary requisites for us to teach that type of trade. So it's not really learning theories alone. We want the people to have what it takes to do their hands-on as well. But really, these are the principles I think that we must agree on. If we agree on the principles, then it's very easy for us to judge ourselves going forward. Then there will be no need for us to argue. Should this program be what it is? Is there room for improvement? It will be very easy because we already have the set benchmarks and we are working towards achieving those benchmarks. And what are those benchmarks? In my view, what Professor Manda started with, that's the benchmark. We want to get 5 stars on all those standards. Why? They are achievable, they are realistic, and they are within reach of every nation, so to say, that desires to train good practitioners. We have the capacity to achieve that. And I think we have also the goodwill to get there. What we need to do now is to put demands on the system to provide what it needs for us to take ourselves to that level. Ladies and gentlemen, I hope I have laid down what is coming from HPCZ as being the way to look at this particular problem and to see how well we can move forward. But really, in our discussions, let's say it as it is. where are we right now and how can we progress better? Thank you very much.
Good afternoon. I'm Dr. Clay Sisiwale, Member Secretary. I'll be running you through the Q&A. I would ask the presenters to come forward. So during this Q&A, firstly we'll have 3 rounds of questions, 3 rounds of Q&A. Each round will have 3 questions. So how we're going to run it is that each person asking a question should limit their submission to at least 2 minutes. Let the submission be concise and relevant. So we'll start. The presenters are already in front? Okay. Thank you. Okay, we can take the first question. Yes, Dr. Kalima.
Good afternoon. My name is Dr. Kalima Mnalula from Women and Newborn. I have 2 questions, but I want to just make a comment before I ask the questions. I must say that today is the first time I've heard Professor Banda speak more than once, but today is the first time I really understood the significance and importance of medical education and understanding what it actually entails. Thank you for that presentation. So there are 2 questions that I'd like to ask. One, following on the presentation that Dr. Banda gave, and I don't know who I'm actually directing this to. Maybe Professor Banda will answer. Because he gave a presentation saying that there are sort of like 3 streams that a medical doctor can wind up in after training: academic, clinical, and administrative. So my question based on that is, why then do we require trainees to do a clinical internship? If you're going to be an admin, why should you do 18 months rotating through the different departments? Maybe that's something that we need to think about. Do you really need to do 6 months of OBGY if you're going to be a researcher or an admin? Then the second question that I wanted to ask was, we are talking about benchmarks that are going to help the country produce doctors that are recognized beyond our borders. Why then are we letting the universities develop their own curricula of training doctors? Why don't we have one like standard template of the curricula that the universities should follow? Because I think there was a presenter that spoke about if some universities have more faculty than others, maybe with the understanding with the consortium, students can go and learn modules from one that has more. So if the University A has a different curriculum and B has another curriculum, how are you sure that the students moving from A to B are going to be taught what A promised them that they are going to be teaching? Because everybody's has their own curriculum. Why don't we just have one curriculum that everybody is following?
Thank you very much, Dr. Kalima. Dr. Gideon Panja, the gentleman here. Please, let's keep our submission to a maximum of 2.
Thank you so much. My name is Panja Gideon. My question goes to HPCZ. What are we going to do? I think there are over 600 clinical officers that are bridging to become medical doctors without A levels and without, I think, most of the things that were mentioned. And perhaps for those that have already qualified as medical doctors without those prerequisites that have been mentioned, especially in terms of A levels and whatnot, what are we going to do? I think that's my question to HPCZ. And at what point did we change, or at what point are the clinical officers bridging and being exempted in these institutions to start from second year of somebody being a clinical officer, but they start in second year of medical school? I'd love to understand that. Thank you.
Prof, did you get the question? Did you understand the question? Okay, good. Okay. Professor Boa. Professor Boa.
Thank you very much for those excellent presentations. I just wanted to ask Professor Goma a question. Since he speaks so publicly so often, sometimes he speaks in a way that results in him being contradicting himself in a way, I would say. And I remember that in this forum, before he was registrar of HPCZ, he stood and made some very strong comments about the STP program. I think many people were here at that time. And we have been told that the STP program was created as a brainchild of HPCZ, the Ministry of Health, and there are collaboration agreements between the three institutions. And now, Professor Goma finds himself the registrar of HPCZ. And what I want to know is, what is his position in relation to the STP program at this point? Thank you.
Thank you. Thank you very much, Professor Boa. So we'll start with Dr. Sekelani Banda. You can take the first question. That was, I can.
Thank you very much, Dr. Kalima. The triple helix outcome as a guiding of careers of doctors, like you said, they could end up either as administrators, clinicians, or academics. So why do they do clinical internship? The answer is simple. The MBCHB trains people to be clinicians at the level of JRIMO. It does not train people to be academicians. It does not train people to be administrators. Those are things that develop onwards later. So the focus is to train somebody who can function as a JRIMO. So that is why they do a clinical internship. Why develop individual universities develop their own curricula? Why don't we have a standard template? There is a standard template, except the standard template speaks to outcomes. What will you be able to do when you graduate? It does not prescribe the process. The process is to do with educational philosophy. For instance, there are some educators who believe that the best way to train a clinician would be to throw them into the deep end of clinical practice. There are others who believe, no, we should first teach them theory. Let them learn the basic sciences, let them pass how to do this, then take them to clinician. No, that is a matter of process. But at the end of the day, you are all trying to achieve the same thing. Able to take a sensitive history, able to do a differential diagnosis, from there on do a physical examination, confirm, come up with investigations, come up with a definitive differential diagnosis, manage that patient. But the process of how we get to that is dependent on our educational philosophy.